here. We will go ahead and get started. I just have a couple of housekeeping things, and then we will be turning it over to John for today's presentation. Again, we're obligated to show this slide here. It just says everyone involved in this project has no financial relationships to disclose, and we are a grant-funded project funded by the State Opioid Response Grant that comes to us through Nebraska Department of Health and Human Services. And I'm sure everyone here is, or almost everyone here at least, is familiar with our CME process. There'll be a quick evaluation survey that will come to your email. You can also grab that in the chat at the end of the meeting today. Just complete that quick survey, and your CME certificate will pop up. If you ever have any issues with that certificate or need anything related to certificates, just shoot me a quick email, and I'm happy to figure that all out. Just a reminder where we are in our current series here. We do these in cycles of 4. So we are on the second of 4 here. Coming up in 2 weeks, Mary Ellis will be talking about patients with SUD in the justice system. And then Stephanie Bennington will be ending this series with psychosocial challenges with SUD treatment. And I'm going to let our expert panel introduce themselves. So I will stop sharing my screen. And let's see, Ed, would you like to go first?
Yeah, you bet. Thanks, Will. Hey, good morning, everybody. Ed Kaiser here, family nurse practitioner located in Omaha, Nebraska. Been working with substance use for the last 7 years, so excited to be with you guys this morning.
Thanks, Ed. And Mary?
Good morning, Mary Ellis. I'm a psychiatric nurse practitioner and attorney, and I work in the Omaha and surrounding communities.
Thanks, Mary. And Alex?
Morning, Alex DeWork. I'm a family physician who works at an FQHC with an interest in infectious diseases and substance use. I'm glad to be here.
Thank you. And Todd?
Good morning, Todd Stoll. I'm a psychiatrist.
Thank you, Todd. And I will introduce Stephanie Bennington. She's joining us, but she sent me sent me an email that she's sick today. So Stephanie Bennington's also here with us. She's got her camera off. She is an addiction psychiatrist practicing in Rapid City and Chadron. And just a quick reminder before I turn it over to Dr. Massey, if you ever want a consult with any of our experts, just get in touch with me and I can make that connection. We're always happy to do that for our ECHO participants. So with that, John, I'll turn it over to you.
Good morning. I'm John, and I'm a pain physician in Lincoln, some other spots, and I'm happy to get to talk today. We'll see how I do with this. We were practicing and see. All right, so tell me when you can see it okay. How's that?
That looks good.
All right, so I'm really talking today. This is the substance use and pain ECHO project. We've spent a lot of time talking about how pain conditions, substance use conditions, and mood disorders are interrelated in that Venn diagram. And today I wanted to kind of talk about some of those aspects from a pain perspective. Try to come up with some cases, talk about some issues, and how I think we might all reflect on those conditions as they interrelate with each other. And really, the thesis statement of this is how to provide integrative care in a fashion that's both effective and cost effective and respectful of the needs of the patient. So I was really thinking about that a lot over the last few days and a couple weeks. And one of the things that I enjoyed was kind of going back into some of our literature and our data and some of the history of this. And part of that for me was I was recently at a wedding of a close friend of mine's son who's a medical student in Vermont. He actually he has as attending some of those physicians who do that Bridges program that Dr. Lydiat works with so effectively and that most of us have heard about. But then we went up to Montreal for a few days, and Montreal, for my specialty at least, and I think a lot of us, the McGill University in particular, is kind of like the Hogwarts of modern pain medicine. Ronald Melzak was there, and he did just fantastic work in terms of getting us to respect pain as its own disease and how to measure it, how to quantify it, how to look at it in a more scientific fashion, while at the same time, as we know, he was a psychologist, so he really did a lot to codify what we do. And the amazing part about this for me is how old and yet how sort of golden some of his work was. We all know about Melzack and Wall and the gate theory. Patrick Wall was a British person, and this is a picture of McGill. I just had a chance to see it, and I also interested in the fact that it was formed by the family that owned Molson Brewery. That's how they decided to um, kind of spend their philanthropic money with beer is to fund a great university in Canada. But the MPQ, the McGill Pain Questionnaire, came out of a really kind of a lot of collaborative research and discussion, and it was an attempt to try to use a universal language to express the way pain feels under different circumstances. And with the work that's been done over the last maybe 50 years now, I have to do the math, probably a little bit more. I think it came out in 71 or late 60s, even earlier. The work that was done on this has been validated to show lots of things that are important about what we need to be assessing with pain today. And it should, in some ways at least, drive our thinking about how to manage these patients. So we've all seen, we've heard about the MPQ probably. It's something that maybe we don't work with very often. Specifically, it is kind of the gold standard in terms of treatment. If we're going to do something interventional for pain, if we're going to do fusion surgery or we're going to do some meaningful event, this is something that has been shown to be a very important measure, holistically managing the kinds of things that we do for patients and whether they're effective and long lasting, and whether they address the root of the problem. And what's really nice about the MPQ is that it evaluates all the different aspects of the pain experience and in a quantifiable fashion. It takes about 5 minutes to do. We were talking about this. We don't always do this for our patients, but we do a version of this, or we do something similar to this for our patients to be sure that we're managing patients effectively. It's really, the number that we all use is the VAS, right? The visual acuity scale, where we talk about pain on a 1 to 10 scale. In chronic pain management, at least, we have a saying that patients tend to become sort of tattoo their VAS on their shoulder. It's like their patient identifier number, and it's a very static number, and it sometimes just reflects the mood of the day in some ways. So it's not a very good measure, but MPQ and measures like this are much more effective. And what we know about it is that first it talks about the sensory component of pain. How does it feel? What are the types of sensations the particular pain pattern gives us? The sensory portion is the first axis of pain that we're assessing with this. The second part is the affective, and that is how does the patient feel in a more holistic fashion? What is the emotional component of this, and what's the import of that? Then the third axis of this is the evaluative. That is, how does the patient interpret what this means with respect to how it impacts their day, their life, and what have you. And then the last is sort of the scale, that is the intensity of this experience. And different pain problems have very characteristic presentations. And as we have gone through in time in the 1960s and 70s, many of the pain states that we now routinely treat and commonly diagnose and can come up with very effective treatments for, we didn't really have a good understanding of what the pathways are, what the specific neurobiology was. But this kind of language helps us a great deal. And In previous lectures, I've talked about the pain pathways, the neurophysiology. If you remember talking about the nociceptive pain and how there's something at the tissue level and you're getting a valid response of the central nervous system, and that valid response then gives us a scaled signal that reflects the amount of tissue damage. And then we talked about neuropathic pain, peripheral neuropathic pain be another version of nociceptive pain, something wrong with the tissue and the nerves and in the tissue. But then of course, the more challenging situations are the nociplastic pain with central sensitization, and that is when pain's been around long enough that it's starting to change and the pathways involved are different. And that's when the signal begins to change subjectively for the patient, and they'll start marking this differently. The sensory portion of this is we sometimes talk about the lateral pathways. That is, the spinal thalamic tract gets involved, and you talk about, I can localize this pain. It's this type of sensation in this location. It goes to the lateral aspect of the cortex. It's very easy in a homuncular fashion to say this sensation in this tissue feels like this in my brain. But the more affective components that are coming out of the middle part of that MPQ that tend to accumulate over time, that reflects a change in the physiology where now the spinal mesencephalic tracts are more involved. You get the limbic system activation and the other more deeper brain structures involved, the more difficult to manage kind of conditions. And this is really reflected in how how an MPQ would look for any given patient at any given time. Certainly the PPI and the scales and what have you then also indicate the degree of the problem at the present moment that the test was taken. So it's one of the really effective ways that we can manage this. And it's even something that can give us important diagnostic information when we're trying to discern between two very similar pain complaints. I'll show you a little bit that here in a second. But the knock on the MPQ is that, yep, it's great for research. It's great if you're trying to prove that a new therapeutic endeavor works and you're going to get 100 patients or 1,000 patients and do a study, but it's a real hassle. We can't use it in clinic. And we share that opinion sometimes, but at the end of the day, this is a process that takes on the outside 5 minutes. So I really want to kind of think about the import of what it means to say that making a meaningful difference in the diagnosis and assessment of our patients in a holistic fashion requires a 5-minute investment of our clinic time. We're obviously using other measures, and we're doing a lot of other work for our patients, but it's essentially this conundrum of these difficult to treat chronic pain patients. It's a solvable condition, and it's not recently solvable. It's been solvable for decades, and maybe the problem is a little bit different as a result. So show you a little bit what I mean. We know that patients with similar conditions across the spectrum will respond with very similar kinds of responses on the MPQ. What does that look like? And sometimes it's just a matter of scale. Causalgia, which we currently call complex regional pain syndrome, which is one of our worst nociplastic conditions. It's very life-limiting and debilitating, and patients very often aren't able to function in their life with this kind of a condition. It has a very high MPQ score with respect to the intensity and the presentation, but it compares actually worse to something like an acute amputation of a digit, which we understand to be very painful. We all understand the ideas of childbirth and how significant that can be, and other kinds of pain conditions that are more chronic and rather than subacute and acute, and they still have very high pain scores with respect to the MPQ and how it relates. But also, we can discern between different kinds of conditions within the MPQ. And one example that I like to give a lot that I think is one that we see frequently is the idea of low back pain from an etiology that we can identify. And we often talk about the most common reason for low back pain being vertebrogenic or discogenic, as we used to call it. And that's something that's an acute problem with the weight-bearing portion of the lumbar spine. It's the most common diagnosis of chronic pain outside of headaches. And we can use the MPQ to give us pretty good diagnostic information as to whether there is an acute injury like that in the back, or whether we're dealing with something that's more of a chronic non-nociceptive. That is, there's not an ongoing tissue injury, and a patient will respond with an MPQ test one way or another. And that's going to motivate us to say whether we're going to send somebody to physical therapy, whether we're going to do, some of our cognitive behavioral tricks that we can do, whether we're going to give education about how to functionally get through the day, or whether we're going to get an MRI done and start working on some procedural thing that we need to do. That is a surprising amount of discernment that we can get from something as easy as a 5-minute test, but it shows you the scale of the problem with respect to how we deal with this condition in medicine in the US. Another example that I like about this one a lot that's really intriguing to me, we have as a pain clinician, I'm very often sent referrals for trigeminal neuralgia, right? People understand trigeminal neuralgia to be one of the very most exquisitely painful condition. It was kind of described as the suicide disease in the 19th century. It was so painful that people, couldn't find a way to manage, and they very often just were hopeless with this. Trigeminal neuralgia is an abnormality of the trigeminal ganglion at a special spot as it's narrowed in the canal as it comes out of the head, if we remember our head and neck anatomy. Atypical facial pain is that amount of discomfort, but now it's not specifically related to a problem within the canal of the trigeminal nerve. In other words, it feels very similar. Patients can very frequently start out with trigeminal neuralgia and end up with atypical facial pain, and they continue to get treatment for trigeminal neuralgia, which can include things like gamma knife therapy and neurosurgical open craniotomy. But the point on this is that atypical facial pain is essentially nociplastic central nervous system changes that have occurred quite possibly as a result of the initial insult of the trigeminal ganglion within the canal, but now that has evolved into a chronic pain state. And so if you have it gives us clues as it presents. For example, classically, we say trigeminal neuralgia can't last for more than 1 minute at a time, and then it goes away for at least 5 minutes, and it comes back through the day very electrical, and it's treated with things like carbamazepine, Tegretol, and what have you. But atypical facial pain is now when that sticks around longer. So they start to go from 1 minute episodes to it's around for an hour, or it's around anytime I'm quiet, or what have you. We can tell the difference in a population. We can tell a difference in atypical facial pain diagnostically and trigeminal neuralgia diagnostically with a measure like the MPQ, which is just a questionnaire. How does it feel, and how does it make you feel? So I think that's really kind of a critical thought to have when we're talking about it's very difficult to manage pain patients. It's all subjective and what have you. My response to that is yes, it is, until we look at it enough and it becomes more and more discernible as we go through time. So acute pain, I've talked about this a lot in previous lectures. Acute pain is very nociceptive. What we mean by that is there's an abnormality at a tissue level somewhere. And so if you can fix that abnormality, you can make the pain go away, or essentially almost treat it totally. It's very sensory. The less effective component is somewhat counterintuitive, right? Sometimes it's an injury, it's acute, it's very traumatic, but but effectively, patients interpret this as, oh, I've injured this structure. I need to make this structure better. And so that interpretive evaluative component is reported differently in an acute injury, wouldn't it be? So if we can just fix the problem, and so many times when we're talking about multimodal pain, our hospital has a multimodal pain team and what have you, that's great. But what they're really talking about is we're going to manage acute pain with as few opioids as possible. It's a laudable goal. It makes sense because we're focusing on the nociceptive tissue level, but really the multimodal treatment is generally just directed at the sensory input of this. Like, let's make a block work so somebody recovers from their total knee arthroplasty in order to get out of the hospital. It's very important, but it doesn't fundamentally change in the long term what we have to do for chronic pain. In acute pain. In acute pain, we need to fix the injury and then see what we're left with. So acute pain is pretty easy to manage from the standpoint of just go do the right things, and generally this gets better as long as you don't have certain kind of pre-existing conditions that elevate the risk of acute pain turning into chronic pain or nociplastic pain. What's very interesting about following patients with chronic pain and nociplastic pain is that what happens over time as we really look at their evaluation is that the sensory component of this is very similar. They will use the same type of terms throughout their care over the course of weeks, months, and years. They'll say it's a shooting sensation here, it's an aching sensation here, it bothers me in this way, and this is how it feels. But the effective and evaluative interpretation and scales of those patients escalate over time. They change. So it's not just the degree to which it hurts. So it's not somebody that, if we're not effectively treating chronic pain, they're not saying to us, it used to be a 4 and now it's a 5 and this year it's a 6. They're not even saying that with respect to those kinds of scales, the numeric scales. What they're saying is it's more agonizing. It bothers me more. All of the affective component, which doesn't only I don't think it's adequate enough to say, well, that means they're just starting to respond to the chronicity of it. It's probably also important for us to use terminology that says the physiology is changing, right? Because whenever we're talking about the psychological, the behavioral manifestations of an illness, fundamentally that's neurobiological as well. And why we want to think of it that way is we want to be sure we're communicating in that way, right? Because it's very dismissive of a patient to say, oh, look, you're starting to get more anxious about your chronic nature of your pain, or you're more depressed about this. That's an immediate turnoff. They're recognizing that as dismissive, and now you've lost the opportunity to manage them. But if we can use terminology that sort of says, yeah, over time, this is changing for you, isn't it? It's affecting you in other ways as well. So that is why we need to manage this differently. And so very fascinating to me that some simple measures can prove to us where we are on that spectrum of going from acute to chronic, from going from nociplastic to sensory to nociplastic. And we're terrible at this, aren't we? The thing I want to sit here and say is we spend a lot of time talking about we want to avoid opioids for chronic pain when it's not effective. We want to prevent ourselves from prescribing in a fashion we're harming lots of people, and etc. But fundamentally, the much bigger problem is this: we're not good in the United States of America at managing chronic pain, as many other countries are, for a number of reasons. But we need to remind ourselves that chronic pain is the biggest problem to the U.S. healthcare economy every year. It's more expensive than chronic heart disease, diabetes, and cancer combined with respect to direct care applied to this, partly due to the number of people with the condition being much higher. But the other thing is, and we've understood this for a very long time, is that the indirect cost, that is the societal cost associated with the fact that we're not managing our chronic pain patients effectively is 10 times higher than any other disease we know. That reflects the idea that these people are losing their functional status. They're no longer participating in their lives, their families' lives, the economy. They're going from being happy, productive people to people who are debilitated in a fashion that is out of perspective to what it ought to be if we were doing a little bit better job with this and thinking about this slightly differently. So why is that unique to the United States of America? It's very easy to say, well, yep, it's pretty easy. We've got a crazy healthcare system that's disjointed, it's all that, but it's probably a little bit more than that, although that's part of it. I've talked in the past, this is just kind of reminding ourselves of some of the things that we've talked about in the past. Talked about acute versus chronic treatment and the recommendations, acute care or nociceptive pain. When we can go do something to arrest this problem, we should do that as long as we're paying attention to the other component of this. So we talk about the anatomic procedures. What's different between 1968 when Melzack and Wall came out with the gate theory, and what's different than when we were first looking at this is there has been a lot of attention paid to this. So now we are exquisitely good at coming up with a diagnosis for the most common conditions that we have. Low back pain, I would make an argument all day long that if we look at low back pain in an organized fashion with the right knowledge and judicious use of the available tools, we can make a diagnosis as to the cause of low back pain in the great majority of cases. And it's more than just pinched nerves and slipped discs. And we can get to that in other discussions, but we can come up with that nociceptive source and treat it when appropriate. But we also need to know exactly when to back away and when to avoid going into that because other things are going on. And the area where we probably get really stuck in the United States is we have when we have limited resources, we try to manage one condition with treatment really that's designated for other conditions. And our medication strategies for acute pain are effective, and our medication strategies for chronic pain are more difficult than with acute pain, less completely effective than acute pain by a long shot, but also they tend to become problematic, which is why this is part of the echo, right? We are here essentially because we try to bridge people with medications with high levels of potential complications, especially in the people selected for those treatments, as well as diminishing return. And then when we get stuck and we don't know how to go from door A to door B, we run into trouble. So that's kind of the nature of this problem. And to me, it's much greater than just, do you have substance abuse or do you not? Do we need to stop prescribing or do we not? We need to talk about the why and the how. So remember, nociceptive source for anatomic. When we're managing our patients, the third element of this, and it's probably not the third element, it's probably the first element, is the functional status. When we're managing patients comprehensively, the number one thing we want to measure besides all those scales we're talking about is what is going on functionally with the patient, because that is the report card that we should use to say this is better or no, it's not. When you have somebody with substance use or substance misuse and use disorder, they're going to be inexorably less functional than when they're under treatment for that. That makes sense to us. If somebody's got an injury, as soon as it gets better, their functional status should improve concordantly. And if the functional status is declining and they're saying everything's great, it's not great. So we have to think about that. And the third element of this, and where I want to just make the point to emphasize on this, when we're talking about behavioral issues, we're not talking about just mood and affect. Yes or no, do you feel depressed? Yes or no, are you anxious? What we really want to be thinking about for patients is how are they doing interacting with their disease process? Are they passive versus actively managing this. And I think one of the most overlooked elements of this is the idea of, are you insightful as to your behavioral state, your behavioral status, or are you submerged? Because it's just pathognomonic in the Midwest with farmers and all these other people that they come in and they don't show up until harvest is over, and they bring their leg in with them because it fell off halfway through the harvest, right? Or somebody who comes in and they're everything's fine, they don't want to talk about it, but everything's not fine, and that's not because their behavioral condition is good. It's because they've submerged it so much that they're not going to communicate that to themselves, much less to some provider sitting in an exam room. And why that's critical is, how does that pop up? They'll let themselves talk about that in terms of the physical experience of pain. And that is, the somatic variants of mood issues are really prevalent in individuals. And finding the motivational interviewing skills to get at that and understand that in a fashion that works is very important. So again, just kind of reiteration of what I'm talking about here is, this is why we're here at Echo. Anybody who's sitting through this boring hour is somebody who's kind of, I know I'm preaching to the choir on this, but I hope that we can do a better job managing this holistically. And the one thing I also want to say about this is, where the US is different is we have more siloed care than everywhere else, right? It's based on what hospital somebody is affiliated with, what their insurance carrier is, and geographically in Nebraska, we're very limited because all of the resources aren't around easily. We have to make a real effort. And why we want to do that with multidimensional nature of this care is, if you're doing the right thing for a patient and managing them with all the elements of this, if they perceive this as sequential, they always have a tendency to say, okay, well, I tried medicine, that didn't work. I was sent to this doctor, he did some injections, that didn't work. I was sent to this surgeon, that didn't work. Then I was sent to physical therapy, that didn't work. And then I was sent to, for some CBT or something, and that didn't work. When really, maybe everything was appropriate and working at the same time, but the fact that the patient was going from one to one to one to one made them feel like something was wrong because they were still having some complaint. So if we don't integrate, that's at our fault. So I want to talk about some patients about this, and I want to talk about kind of how that can present to us, and how maybe backing out at the right time or proceeding forward with the change in care can make all the difference if we're thinking about this. And then I'm going to show you how it can fall apart if we're not doing it right as well. First case I wanted to bring forward is, and these are I actually, these are all patients. They're all patients that that we've seen within the last period of time, and it's striking to me how easy it is to find these patients that are kind of difficult to manage. This is a middle 50s patient who's had multiple surgical procedures, really extended fusions from T10 now to the sacrum, and really the entirety of the cervical spine. This patient came to me after being kind of forced to move for family reasons, had been in another environment, and they'd been given 120 milligrams a day of morphine, 15 milligrams of oxycodone 5 times daily, muscle relaxants, pregabalin, uh, duloxetine. Came in on the first visit. How's it going? I'm here because I need a new doctor. Nobody will treat me. Always, I have enough medication to get to this first visit. Okay, how's it been going? It's been going fine. I've got the right treatment. It took me a long time to get at it. We do the first VAS and it's 8 out of 10. And critically, the Swestry Disability Index is 58. That's before we start doing things like the MPQ or some of the other scales that we can measure. And now we're stuck with this patient. How's it going? And this is a chance. Does anybody want to weigh in on thoughts about, where we would go if we were sitting with this patient in an exam room on the first visit? The echo does have an element of back and forth to it if you want. I'm happy to talk, but does anybody want to think about what maybe would it be a good idea for a first step, or how we could approach this and what the challenges might be?
Yeah, I see Roger Myers clicked the
Awesome.
hand raise button. Do you want to
Uh,
say something? You
Thank
want to
you.
speak up,
Yeah,
Roger?
yeah, please.
Yes, thank you. Yeah, I'm here at University of Nebraska Medical Center. I actually do have chronic lower back pain that is in the process of being worked on. So to chime in on this, one thing that I always think about when I go to see my own pain docs is they never really ask me how long I've been on these medications and if it has shown any effectiveness throughout my duration on them.
Yeah.
So that'd probably be a good first start for me.
That's an excellent point, and I appreciate that. And I think another way to think about that is every clinician, what is that cognitive bias, the congruency bias or something, where we kind of confirm our own bias just by watching it long enough, and and we're all susceptible to that, and I would make the point that that's one of the biggest problems, right? Because it takes a certain activation energy to say what's going, is this really going well, and do we have options? And it's very common for people to get stuck, patients and clinicians. But again, that's why we're here, because this is my postulate is this is manageable, and how we manage it is critical, and it's again not that hard to make this situation better over time. Anyone else want to make a comment before I jabber on?
Yeah, go ahead, Alex.
I think at our clinic we built in a process to try to automate this with our clinical pharmacists. But one of my questions would be, do you have Narcan on hand? Have you been screened for sleep apnea? Because yeah, I would say, there's some definite unavoidable risk that comes with these medicines, and we want to make sure that we're keeping you safe. And if you have sleep apnea, that increases the risk significantly with these sedating meds. And then it also asks about, like you said, function is the report card. What are you able to do in your life that matters to you and that's important to you? And are there things that you can't do that we can try to help you get back to doing?
Excellent points, Alex. And I'll say this, the clue here is an ODI of 58. That is a limit, that is a measure of functional limitations associated with back pain that is equivalent to somebody who's paralyzed in a wheelchair. That is fully disabled. So the answer to that is not well, right? They show up, they're telling us objectively, I can't do anything because of the amount of back pain that I'm experiencing. Excellent points. I appreciate that. To me, the critical part about this, and I think, I want to make this point today because I've had this discussion in other meetings. We have excellent data that shows when you're on these very high MME doses of opioids for chronic back pain that has been managed over time, like Roger was saying, switching therapeutically to buprenorphine is the number one um, advantage we can give patients, not just because it will improve safety, it will subjectively improve their experience of chronic pain. If you don't remember my data from previous talks, I can bring it forward again, but it has been clearly demonstrated by studies that look at this in the absence of use disorders with opioids that switching to buprenorphine therapy will reduce commonly the VAS from a patient from 8 out of 10 down to 2.5 or 3. I cannot think of a procedure that I can do that has better data on that, and I have a lot of neat procedures. So finding a way to get a patient to understand that, to me, the first steps is exactly what these guys were saying. Evaluate whether this is working. I'd agree with Roger that it's not. Listen to Alex and say, all right, let's protect this patient acutely. Let's watch for, let's do a stopgap and, measure for OSA. Let's get Narcan. Let's talk about why that's important. But for me, the first step is to say, before we do anything else to you, I need to hear from you how invested you are in what you're doing because nobody's going to like the idea of a switch. And could I explain to you how a medication switch is going to improve your pain? And then they're going to say, oh, I've heard about buprenorphine. That's the one that takes me to the dentist because my teeth rot out and it's for heroin addicts. Why would you say that? Do you think I have a problem? And I need to use the language. I don't have anything here that says that you have a problem. I would not skirt around that. If we figured you had a problem, we'd talk about that, but only with respect to the subjective experience of pain. I will make you better predictably with data behind it if you allow me to find a way to switch you into buprenorphine therapy. It works and it's effective and it's easier to do than we think. So to me, the first thing is to align the patient, make those points. Roger, your points were perfect in that. That's exactly how a patient's going to respond almost all the time. And then say, this is an opportunity. I'm a new face. We've got another way to go. Are you ready for it, or do you want to think about it for a month? And you must, I think you must give them that option, because motivational interviewing says it's not me telling you what to do. It's you and I looking at this problem differently. So if I say to them, yeah, I don't love these medicines. I don't think they're working for you as you think they might. When you're ready, let's change. And can I start talking about that now? It's a very effective way to get people into this treatment. And as long as you understand how to do it and what to do with that, it can make a big difference, right? So that's to me, though, you guys hit on exactly those points. So and I'll just anecdotally say that we did that with this patient. We waited a month, and on the second month, we had a microdose initiation ready to go. And this patient was anxious because they were in a rural area. It took them a while to kind of get to it. So it took us about 2 weeks, almost 3 weeks, to get them fully switched over. But within 2 weeks after being switched over, they came in, and the wife came in for the first time just to make the point that I haven't seen my husband in years. He feels better. How come this medication wasn't on board before? And that's kind of why we're here, right? So let's go to another case. I don't want to. Oh, did I go through all my? I see. All right. We got another one. This guy's on methadone. It's a new medicine. It's similar to methadone, I guess. But this patient's on had a smaller fusion, a two-level fusion, a little older individual, had been on methadone and oxycodone, again, higher doses of this, failed back or post-laminectomy syndrome, persistent leg pain and back pain. This patient had been somewhere else, and because of the very high doses of oral medications, and the fact that the patient was consistently saying, "Hey, I'm not doing well on these medications," and the MME was above CDC guidelines or whatever, the patient underwent a spinal cord stimulator trial, which was successful enough to lead to an implantation of the stimulator, and within 12 to 18 months, that wasn't working very well. It continued to provide what we say is paresthesia overlap. It was stimulating the right area. It wasn't solving the problem for the patient. Patient was still having back and leg pain. So in a somewhat unorthodox fashion, while the stimulator was still in place, uh, a morphine intrathecal pump was placed for this patient, and that had happened about 5 years prior to my initial visit with the patient. And the patient came in, consequently had been off of the oxycodone, off of the daily methadone BID, but was now on preservative-free morphine at a dose of 2.5 milligrams intrathecally. And so, just for knowledge base, you basically take that number times 300 to come up with an MME that would be equivalent to an oral dose. So essentially, this patient comes in on 700 MME, intrathecally administered, saying, my pain is 9 out of 10. I can't walk anywhere. I can't sleep. I'm not doing anything. Will you, and the question was, will you put in a ziconotide for this for me, which is a type of snail venom which works for neuropathic pain, and it's kind of one of the expensive medications we can put in pumps. My provider couldn't get it for me, and it was really related to insurance issues. What do we do? So that the same question kind of applies here. what's going on? Why isn't this working? And where could we go from here? Anybody want to ask a question or clarification or come up with a suggestion?
Feel free to speak up or yeah, Alex has his hand raised. Go ahead, Alex.
Thank you,
Yeah.
sir.
At this dose, I was wondering, is opioid-induced hyperalgesia part of it, and could the high dose actually be part of the problem of why everything hurts so much?
Yeah, that's certainly a question on this. And I don't know if I don't know if I know that answer. That's kind of a way we think about this. Um, and similar to this, though, one of the things that I think has been really shown with intrathecal medication delivery is if a medication is really ineffective orally, and it's not that it's just not tolerated, but it's really not helping, and so you cannot translate that into intrathecal medication unless you have a short time frame. It's very similar to, when we used to do a lot of neurolytic blocks for cancer pain patients. We're like, if you've got uh, pancreatic cancer, we can do a celiac plexus block and everybody gets better. But if people have chronic pancreatitis and we lyse those same nerves, then they get better for a year and a half and then they get absolutely worse. I think it's a little bit like that, where the medication, you're just now efficiently giving a medication that never worked in the first place. And but a good point. It may be a version of hyperalgesia for sure. Yeah. This one was interesting to me, and I'll get to where this reflected to me. So one of the things I really thought about is this patient has had essentially everything kind of looked at in the past and what have you, and hadn't responded kind of in a serial fashion to intervention, 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 intervention. And really, the nice part about this was, even though that is a very high MME for the management of pain, it's not that difficult to translate this kind of a patient into buprenorphine therapy. I'm sorry to be kind of a broken uh, uh, record on that, but this gentleman wasn't taking any oral opioids, or if he was taking a, 3 5 milligram hydrocodone a day because somebody did that just to help him feel better until he could get to us. But when we placed this gentleman on buprenorphine on and the total body dose of morphine was just 2.5 milligrams, we were able to almost immediately discontinue the intrathecal morphine. And the buprenorphine microdose initiation has so far, now 3 months out, worked spectacularly for that chronic pain that's around all throughout the day. It did not take a full month for the patient to say, this is much more effective than the medication in my pump. How does that sound with respect to the healthcare costs associated with the long-term management of a patient that we think is going to live 15 more years and has already had, 20 years of care? This is a medication that they put under their tongue twice a day and just stay stable on that medication. And yet, because high dose oral opioids weren't working, we didn't think about switching over. And the part about this that I bring that forward then is the patient was saying, I feel better while I'm sitting around, but I still can't walk. I still have a problem, and I'm not exercising, and now I'm sleeping poorly. And what we were able to do and how this worked, once we took the pump out, we got an MRI, we found out that this gentleman has developed some stenosis at the junctional level above his fusion. So with that issue and the fact that he's had a fusion from 4 to S1, surgeons aren't going to be wanting to advance that fusion any higher. He's done poorly with that with respect to the back pain. However, we were able to offer an outpatient procedure to this gentleman, a mild procedure, which you can do at that junctional level. And that made him go from being able to walk 50 yards. Now he can walk for up to a mile and stand for up to an hour. And he's able to handle that functional component. which really had nothing to do with all the care that had failed him in the past, but he had developed a new problem. But he kind of had these spectacularly failed treatments around him as a fence that kept other people from wanting to look into it. And one of those treatments, I think, was the intrathecal medication, which just wasn't working. But again, it kind of probably reflects, again, we're talking about that that kind of bias that we get, the congruency bias, where you're just sort of like, well, we got to keep doing what we've been doing because we've been doing it so long. I can't think of a better way. This
Hey,
one, oh,
oh, hey,
sorry.
John, sorry to interrupt you. There's a question in the chat and then a case in the chat that, if you have time, would you be willing to comment on that?
Yep. I
Okay,
do you want me to go through one more?
it's up to you. We've got like 8 minutes.
Okay. I'm gonna present this one because
Okay.
I like this one because I'm the one who messed up here. Um, so I can sit here and look at the care that somebody else has been given and and say, oh, I got a new idea, and that sounds kind of like whatever. But this is me not doing what I could do for an individual, and with kind of I'll present it here. So this is a 52-year-old who had a work-related injury to his hip, ended up and low back, an event that occurred really led to both radiculopathy and needed a labral repair for the hip. I didn't take care of that patient until that point. It was referred to me for a spinal cord stimulator that was because of persistent lumbar radiculopathy after successful microdiscectomy. I got involved. I placed a stimulator. We had a successful trial. It did well for a year and a half. Some intervening event occurred, and now nothing is working. And there's kind of a non-specific injury that occurred that was like another fall or another injury, and now there's a debate about who's on the hook for what. Is this continuation of the old injury, a new one, and all the medical legal aspects of that? But fundamentally, while this is going on, he started taking some oxycodone while we're figuring it out. He was just taking 40 milligrams a day of oxycodone, but it wasn't going very well. And we got a new MRI and we found something modic changes that's that inflammation of the end plate, the vertebral end plate that I've got sort of a representation of on that MRI picture there. And that gives you persistent back pain. When you sit too long, stand, try to work, lift. So it very reasonably would be the reason that he can't return to work and do what he's doing. He's done very poorly. So while we're waiting to prove that to his payers, you can see with medical legal issues, that would be a big issue. And we're also trying to think maybe what we don't want to do is a 3-level fusion for this individual or 2-level fusion at minimum, because then he will never be able to work again. We were able to offer this Intercept procedure, which basically makes vertebrogenic pain go away in individuals by denervating the basivertebral nerve, fixes that back pain problems, got great data behind it and what have you. While we're waiting to do that, I switched him into buprenorphine because I knew that was going to be the long-term plan. I didn't intend to put him on 8 milligrams 3 times a day. That's way higher than his 40 milligrams of oxycodone, but he kept saying it wasn't working, it wasn't working. I do the procedure. It takes 3 months to know how it goes. It's kind of going better, but not very much. At 3 months, we're really done. Everything's been addressed. How are we doing? We got to kind of close this case. He comes in and on that day, he reports an Oswestry disability index of 70% and says, I can't do anything. And his wife says, you got to do something. He's terrible. He's worse. Do we need a new hip surgery? Do we need to go get blah, blah, blah? I've got an ODI of 70%. And in interest of time, I'm gonna tell you what I had failed to really appreciate in this is the risks that can be associated with secondary gain, right? This gentleman did great all up until the time when we say, hey, I think we've done as good as we can do. How about, getting back into the workplace? No, I can't do that. So really what we're doing, he's having on one level or another, probably completely subconsciously, he's got fear avoidance behavior about going back into his duties. He doesn't want to. There's all the legal ramifications of that. I'm really starting to question whether I should have done any of this because an Oswestry disability index above 60% is a functional non-anatomic. And so we ended up getting a functional capacity evaluation on him that was wildly invalid. And basically what was going on is we were not providing we we weren't dealing with an anatomic injury at all. We were dealing with something else going on. And so a lot of healthcare resources probably could have been spent differently. And yet that's what happens when we're not careful about it. I would maybe make the argument we would have done everything because we've now addressed the nociceptive sources, but that's part of that. So let me get to the other case, but I also wanted to say, even when we're trying our best to figure this out, sometimes we don't do best for the patient. How about we get to the
Yeah,
questions of the next case, please?
absolutely. Okay, so I'm going to go to the question first about the previous case, case number two, just a question of what dose of Suboxone did that patient end up on?
On the last patient, great question. That patient ended up on buprenorphine, and the last I knew, they were on zero point 0.5 milligrams, I believe, TID. So essentially, we give them a 2 milligram film of buprenorphine, whether it's got the naloxone in it or not, and they take 3/4 of that film um, each day. So, for less than 30 buprenorphine films a month, we can make that patient feel better and not need to come in every 3 months to have their stomach, you know, injected for refill of a pump with all the attendant concerns. But that does underscore that the translation from one dose of opioids to buprenorphine is variable for patients, and it depends on other physiology going on. Basically, the dependence, the physiology that breaks in. So a lot of times for pain, we're using under 2 milligrams a day of buprenorphine. Great question.
Okay, and then I'll read the case in the chat and you can comment on it. It's from Asia McCoy. Has a patient from California on 180 MME daily. The patient's been on these meds for 30 years and knows the regimen works. Patient's against trying anything else and is meeting multiple roadblocks as the two pain providers have declined continuing her regimen. The medications there are morphine, Norco, Flexerol, Klonopin, Pimozide. Back, neck, shoulder pain complicated by Tourette's. And then Asia also mentioned they talked about palliative care approach when looking at this option. Palliative care in this area only done with hospice.
Great question. That's just kind of the index kind of problem that we face. And the simple answer, and I just say right now, if you can reference our old discussion, I did a buprenorphine microdose initiation echo lecture. Essentially, the strategy is this: you do not have to confront your patient about, oh, I don't think this medicine is working as well, and your physicians just need to prescribe it. What you can say is, how about I add in another medicine that we have data that works better, and we'll add it slowly while you take your current medication. And if you go slowly with buprenorphine, and to paraphrase a full hour discussion, probably more like 3 hours, if you go slowly with buprenorphine and you allow buprenorphine to sneak into the receptors, it will eventually displace the oxycodone and the morphine as well. And what patients do, as you do this process, you start the buprenorphine and you go slow enough so that they just figure out that they don't want their oxycodone and they take less of it because this new medicine is taking away the bad feeling that their current medicine is giving them. And you never confront the patient. This isn't misuse of any kind. You just say, I've got a better pain medication and it's going to work. And you don't have to give them the anxiety of saying we're going to stop it and put you into withdrawal. We just say, let's sneak it in board slowly. And while we do that, you take what you need of your medication for a while. And when you don't, just stop taking it. You find yourself in the predicament of co-prescribing those for a while. And it's a longer discussion, but if you do it that way, it works. And once individuals get to about somewhere around 2 to 4 milligrams of buprenorphine a day for a few days, then they just wean away and they kind of look at themselves in the mirror and say, why don't I need my medicine that I needed so much? This is working better. It's easier to do than we think. Unfortunately, a lot of pain doctors haven't caught on to that yet. And so that's part of this. Does that answer your question?
Yeah, thank you. And Asia, I will send over John's lecture, a video of John's lecture and his slides on that microdosing to you later today. Um, well, thank you, John. Great presentation as always. There's a link in the chat if you want to grab that survey now. Also be an email coming out in about an hour or so. And yeah, get in touch with me if you would like a consult with any of our experts. We can make that happen. Otherwise, we'll hope to see you guys in 2 weeks for Mary's discussion on. I'm sorry, there's another question in the chat. Yeah, I can send out the microdosing thing. I can just send that out to everyone on here since folks might be interested in that. I'll just include that in my follow-up email. So yeah, 2 weeks. Mary Ellis will be discussing patients in the justice system. Hope to see y'all then. Thank you.